lots of the time patients will come with one of two things. They'll come to me because they've got some kind of refractive error or prescription. So they'll either be long-sighted or short-sighted, plus or minus presbyopia. They'll become presbyopic. So we spoke about this in one of the previous videos, but they lose the ability to see up close, which is an aging process that happens to most of us from 45 and over. So there's two factors going on. There's usually a script and there's usually presbyopia. Sometimes it's just presbyopia on its own. So these patients are then put into our clinic and they go through the whole process. So they get their corneas examined. We see if they're candidates for laser. And as we've discussed in previous videos, there's lots of factors that might preclude them from being laser candidates. So, thin corneas, abnormal topography, dry eye. We've spoken about this in detail. So I think they all go into this kind of box. Can they do laser or lens? Now, some people will be able to do both. Some people will be better candidates for laser and some people will be better candidates for lens. The better candidates for lens, if anyone has cataract, so clouding of that lens or any lens related changes, straight away they should have lens surgery. That's easy because if they've already got changes, we're not going to be doing laser on the cornea when their lens has already got age related changes because their script is going to keep changing and they won't get a stable result with the laser, right? So for those patients, it's easy. If you've got early cataract, you get cataract surgery. It's a no-brainer. It's harder for the patients who are candidates for both. And usually most people, if they're candidates for both, they'll opt for the laser because it's less invasive, okay? So if they're younger and they don't have any cataract, so it's just a clear lens, but they can get the laser, most people will get the laser. Then there's a small cohort of people that aren't candidates for laser that will have a clear lens extraction. Does that make sense?
Yeah, sure. Yeah. And so what about ICL then in that case?
That's a different thing. So ICL is purely fixing, it's not presbyopia. This is more for younger patients. So what I was just talking about for cataract and refractive lens exchange, we're really talking about 50, 55 and over, okay? For young patients in their 20s or 30s or 40s who have very high scripts, or even if they don't have high scripts, I've done low scripts as well. But if they're not candidates for laser, again, because of all the factors, lots of the time it's thin corneas and things like that, then they can have these implantable Collamer lenses or these implantable contact lenses custom made. And this doesn't touch their natural lens. This is for young patients who just want to get out of glasses or contacts. And the beauty of it is that it's reversible because we're not altering the corneal architecture. We're not removing tissue. It's reversible, so you can always have that contact lens taken out. Obviously, it's done in an operating theatre, so it's not quite as simple as just whipping it out in clinic. Like you still have to go back and have an eye operation, but it is reversible. And, I put these in 20 and 30-year-olds all the time. And then later on in life, when they're 60 or 70 and they develop a cataract, then it stays in their eye their whole life. We take it out at the time of cataract surgery, and then we go on and remove their natural lens and put in the artificial lens for cataract surgery. So it's something that can be with them their whole life until they develop a cataract.
So would implantable Collamer lenses also be a good option for somebody who has severe dry eye syndrome then?
Yeah. I mean, it will still cause a little bit of dryness because all eye surgery does, but it might be a better option. Although we do have Smile as well, which is good for dry eyes. So look, I think this is a case-by-case thing. This is what I keep harping on about, but it's very true. It comes down to many factors, but like a lot of the time with ICLs, it's in people that have high scripts. I commonly do these in high myopes who actually we don't have enough tissue to do the laser, or if doing a laser in someone with that script might cause instability of the cornea or regression of the script down the track. So that's like the most common scenario. But as I said, if you're not a candidate for laser, you can have these in lots of different scenarios, even with like a -2 or a -1